Americans have more economic anxiety about healthcare costs than anything else, according to a KFF poll. We're talking to reporters in Washington and across the country covering that issue and others.
The drops in coverage, we actually won't know the extent until people, have paid their first premiums, but ranging from anywhere from 833,000 to 1.2 million, according to preliminary snapshots of enrollment numbers. But states have been tracking where communities are seeing the most drops. So for example, the Pennsylvania Health Insurance Exchange Authority in recent weeks told me that rural counties were seeing the bigger drops in enrollment.
Joining our Reporters Roundtable are Neda Hassanein, who covers health issues for Stateline, Michael McAuliff, who writes about politics and policy for Modern Healthcare, and Sandhya Raman, who focuses on health policy news for Bloomberg Law.
One of the Democrats running, and they have these jungle primaries out there, so it gets a little bit complicated, is a doctor. And I'll be really curious to see how well he does versus the sort of moderate Republican and the other regular Democrats running. And I think that'll give us a good window into how the voters feel about it, if not necessarily what, the party boss is.
This is Conversations on Healthcare.
Well, welcome to all of you to Conversations on Healthcare.
Well, thanks for having me.
Yeah, absolutely.
For having us.
Thank you for having
Absolutely.
us.
We're looking forward to really a robust discussion on national and state health policy issues. Michael, let's start with you. President Trump is focused his healthcare message right now on affordability. I think we all see that healthcare spending in the U.S. rose over 7% annually between 2022 and 2024. What is the president proposing, and could it work?
Well, his big pitch was his great healthcare plan, and it seems to primarily be focused on drug prices. And it doesn't seem like it has really broad implications for most people, because if you have an employer-sponsored plan, which most of us do, then you're not going to Trump RX, which is this new portal to take advantage of what are essentially coupons that are available there. And it's really not clear how much that will work or impact a lot of people. So I don't think folks are seeing their premiums go up in their paychecks, or if they're on the ACA, seeing how much more they have to pay, feeling like the Trump RX or this idea of savings accounts, health savings accounts, is really going to do much for them. I mean, because I think the savings accounts would be about $1,500 for one person. How much healthcare these days will you buy for $1,500?
Well, Sandhya, you closely cover the Department of Health and Human Services. And so as we talk, we're awaiting the president's proposed budget for the next fiscal year. It does seem to me like it's only been a nanosecond since we finished the last one. But is the feeling that he's going to try and chop away at HHS budgets? And do you think Congress will go along if there's further cost cutting? Or further funding cuts, I should say.
We can expect is just to kind of follow the pattern of what we've seen in the past. I mean, every president uses their budget request as kind of a wish list. No one's going to get everything they want on that wish list, but it is kind of, setting the tone for what they hope Congress will do. So I think what we can kind of expect is that for him to propose decreases across HHS. I think I would especially look for places like NIH and CDC to have proposed smaller amounts, and within that, proposing to cut some programs that don't align with the president's priorities. Things we've seen in the past are, programs related to DEI or, some of this HIV programming. So I would look for that. The other part of it is kind of looking at some of the policy proposals that are also included within that budget request. So again, I would look for things that are MAHA aligned or, promoting the Administration for Healthy America that the administration kind of wants to reshuffle around in HHS. What that entails, we've seen a much bigger push on, nutrition and eating and that compared to some of the other MAHA priorities. So I would look for that. And then I think also along the lines of what Michael said, just some of the drug pricing proposals, things like most favored nations kind of emphasized within that budget proposal.
Well, Michael, let's pick up on Sandhya's MAHA focus. There's reporting that the Make America Healthy Again efforts are unpopular when it comes to changing vaccines, but it appears that the MAHA interest in healthier, more natural food seems to be attracting wide support. It seems that the White House believes this part of MAHA is winning issue. What are you seeing out there?
Well, it's interesting. You have this primary in Texas today where I think it's the agriculture commissioner. I don't remember exactly what the title is, but the man, Sid Miller, who's had the job for like 4 terms, is like he's running aggressively as a MAHA guy. Oh. And his opponent is running aggressively as a MAHA guy. And the Democrat is running aggressively as a MAHA guy. So they're all very, very much interested in all this. And it's sort of gotten a little bit complicated lately with this glyphosate executive order that the president put out, because Kennedy and most of the folks in the MAHA are really worried about pesticides and the impacts on people's health. So, there's this tension in there between the sort of MAGA and the MAHA that's going on right now. But the MAHA stuff is pretty broadly supported, even if on the left, people don't really trust it.
Well, it's hard to argue against healthy food and good diets for everybody. So it's good to have something we can rally around, and I'm sure they're feeling a little bit of that too. But Nada, I'd like to ask you about something that you've written about. Policy decisions have real life consequences, and nowhere is that more true maybe than in healthcare. Can you share with us what you learned about breast cancer survival rates in the Medicaid expansion states?
Yeah, sure. Study by researchers from Howard University and others looked at survival rates from about 1.6 million women ages 40 to 64 who were diagnosed with breast cancer between 2006 and 2021. And they compared survival rates among women living in states that expanded Medicaid eligibility under the Affordable Care Act with rates in states that did not expand Medicaid. And what they found was that women with breast cancer living in states that expanded Medicaid eligibility were less likely to die from the disease. And the researchers found that to be true no matter the disease stage, race or ethnicity, neighborhood income. Women in expansion states whose cancer had spread to other organs, the most advanced stage of disease, saw the most significant decline in deaths. But they did see variability. So Hispanic women saw the largest gains, and Black women and lower income women saw smaller gains, which is concerning, given Black women have higher breast cancer death rates compared to white women. Although fewer cases, they're often diagnosed at a later stage. And so the lead author told me his team is surmising that Black women with breast cancer benefited less in this study, according to the study, from Medicaid expansion, simply because they are disproportionately located in the South, where there are 7 of the non-expansion states.
Nada, let's just stay with you for a moment on really the enhanced Obamacare subsidies, which expired at the end of the year. What has Stateline reported about how states are reacting to insurance premium price hikes?
Yeah, so, the drops in coverage, we actually won't know the extent until people, have paid their first premiums, but ranging from anywhere from 833,000 to 1.2 million, according to preliminary snapshots of enrollment numbers. But states have been tracking where communities are seeing the most drops. So, for example, the Pennsylvania Health Insurance Exchange Authority in recent weeks told me that rural counties were seeing the bigger drops in enrollment. Other states, have said, they're hearing enrollees were holding out for whether Congress would extend the subsidies. My colleague Shalina Chatlani also reported on how at least 10 Democratic-leaning states are actually using their own money to help people buy Obamacare health plans by at least partially replacing the federal tax credits that expired. And some of that state assistance is being offered through programs that existed before the federal subsidies expired. But nonetheless, it is an effort to grapple with this, with the hikes. It's also possible we might see more states wanting to offer a new public option as affordability continues to waver. Nevada actually became the latest state, the third state after Colorado and Washington, to offer a new public option to its state-run exchange. And these are public-private partnerships that are a sort of alternative to private insurance coverage.
Well, Michael, the Trump administration continues to draw attention to what it calls Medicaid fraud in the states. I wonder if you could tell us what's the latest on that front. Are we seeing that across the board? Does it appear to be targeted to the expansion states? Tell us about that.
Well, it appears to be targeted towards blue states, really, and Minnesota is the sort of big example right now. I believe the state just sued to block the administration from halting about $240 or $250 million worth of payments to the Medicaid program. And we actually had a reporter, Bridget Early, at an event today with Dr. Oz. So she asked him about that, and he said, yeah, there's Minnesota is not clear on what their standards are. They haven't been clear on what they're doing to stop fraud. And to be fair, they've, I think, reclaimed around $80 million in 300 different fraud cases. So, you have to decide how much you believe which side. But Dr. Oz said, it's just the bad guys are making it worse for the good guys, and the guardrails are not strong enough. And we're going to do it here in Minnesota, and we're going to do it in these other states where we think it's a particular problem. So I think you will see more of that going forward. And as I said, so far it's been more focused on blue states. I mean, if you just do a quick Google search for Medicaid fraud, you'll see Texas pop up an awful lot. Right now, maybe you can say, well, Texas is popping up so much because they're fighting fraud so well. But, Minnesota was fighting a lot of fraud, too. So it gets very political. But I do think it's going to keep on going as we go into the election season. And that's one way they can say that they're trying to cut costs.
Mm-hmm.
Sandhya, the administration's candidate to be Surgeon General has faced some very tough questions on Capitol Hill. What are her chances for Casey Means' confirmation? It seems like it's in trouble, but they seem to rally behind their candidates at the end of the day.
I mean, I think you're right in that it is definitely one where the path isn't 100% clear if they have the votes. So we have a two-step process. We need to advance through the Senate Health, Education, Labor, and Pensions Committee, where she testified a few days ago, and then through the full Senate. And I think the big hurdle will really be the first vote, because without that, you can't get to the second vote, and there has been some hesitation there. So you have, the leader of the committee, Bill Cassidy, who's had some back and forth power play with RFK Jr. at HHS, and he had a lot of questions for her on vaccines and some of the recommendations on pediatric immunizations. And he did another round of questions, and it's not 100% clear if he was satisfied with all of those responses that he got. He's been a little tight-lipped about which way he's going to go. But I think it will also rely on the fact that Senator Susan Collins and Lisa Murkowski also had some kind of pointed questions where you can't really tell if they're going to be on board. I mean, they question some things like in Means's book, she talks a little bit about personal psychedelic use and, kind of how that would play as the Surgeon General kind of talking about that publicly. And then, just more of the vaccine questions from Senator Murkowski. So I think depending on how the different, continued meetings go, we'll have a better idea on if she can get across the committee level, but it's still unclear if she has the votes at this point.
Remind me, are all three of those senators, Cassidy, Murkowski, and Collins, up for re-election this year?
I'm not sure on when all of them, but Bill Cassidy is the one that is in a pretty contested.
He voted for the
primary challenger.
Right. He voted for the president's impeachment, but I think Collins is up, right?
Yes, she is as well. I'm not sure when the next Alaska election is.
Yeah.
Well, let me stay on vaccines for a minute, if not elections. So, Sandhya, I understand that you're going to be covering a CDC vaccine panel decision regarding what's referred to as COVID-19 injuries. I'm curious, what exactly are they going to be voting on and what are the implications? And there's always been a process for reporting vaccine-related complications, but how is this different, do you think?
So I think this is really interesting because A, there's a lot that we don't know, and B, just because this is kind of outside the jurisdiction of what we've seen from this panel known as ACIP in the past. So what we know from the notice that they've put out is they want to look at COVID-19 vaccine injuries, long COVID, and just how they make different recommendations. We should know more with like a broader agenda closer to when we have the meeting in March. But one thing to consider is we possibly might not have that meeting altogether. There's litigation trying to challenge whether or not that meeting can happen. And so there's a chance it gets pushed more or canceled. But I think you're right. The fact that vaccine injuries are not really something that this panel looks at. They look at how vaccines should be used or not used to limit the spread of communicable diseases. There are other panels within HHS that look at, vaccine injuries for children or, vaccine injuries related to other adverse events. And so it's not guaranteed that they're going to vote on anything specific. The way the notice is written, it's, they'll discuss it and possibly vote on something. But if they do, it could, open a whole new door to what sort of recommendations we make. And what we've seen in the past is traditionally when they recommend something, CDC, signs off on it and it, becomes a full-fledged recommendation. But, we have another thorn in it in that, we have a new acting CDC director now. The head of the NIH, Jay Bhattacharya, is now the head of the CDC in an acting capacity. And so, it's unclear, is he going to sign off in the same way? Is he going to push back a little bit more? I think we have a lot of unknowns on what can happen. And so it makes it a little trickier to know what the implications will be without that, and knowing a little less about two of the new members that were appointed just last week.
We had a number of conversations with leaders around long COVID. How much does that, and maybe to all of you, how much does that animate the health policy conversation down there? Is it getting any traction, or is it pretty much in the rear view mirror?
I haven't heard people talking about it at all for quite a while now. I mean, by the time you get through the big, beautiful bill, the ACA, and now there's a war, long COVID is not long gone, but it's not being talked about.
Right, as is often the case, except for the people
who are
experiencing it and the people who care for them. Yeah. Well, Mark, maybe I can ask you, or I'm sorry, Nada. One issue we've been talking about a lot out here in the front lines is the new Rural Health Transformation Program that's going to be funding state initiatives. And we're curious.
$50 billion.
$50 billion, I might add. Yeah. What are you reporting on regarding this big initiative of the administration?
Yeah, I mean, it is a big initiative. There are a few misnomers around this program. So kind of trying to correct some of misinformation out there around it, but some have been calling it the Rural Hospital Fund. It really is not that. In fact, CMS has put limits on how much can be used for each approved purpose. There's actually a 15% cap on how much of the award can go directly to providers, but there are other ways states can support providers, and they proposed specific ways, including through recruitment efforts, training, that kind of thing. But it's really not clear how much hospitals will effectively benefit or directly or indirectly benefit from the funds. So I'll be interested to see how states continue to sort of support the rural healthcare landscape in that way. CMS isn't requiring public transparency around this. So it's really important to kind of track different states and what they're doing directly. State agencies I've spoken with are saying the money isn't enough to offset the Medicaid cuts over the next decade in the OB3. That being said, I'm really interested in continuing to report on how states are looking to expand access to clinicians. As we all know, part of what rural America suffers from is not only a lack of primary care providers, but also a lack of specialists. whether that's, cardiology, OB/GYN. So I'm looking to shed light on how some states are actually using the funds to try to create regional care networks or virtual ones that facilitate access to specialists for consultation in rural areas, kind of more seamlessly, professional to professional. Another huge gap is maternal health. And while this infusion in money can't fix the system that ultimately favors volume, putting rural areas at a disadvantage, looking into how states' transformation programs are trying to maybe support alternative birthing facilities like birth centers and midwiferys, which can help fill gaps, particularly for low-risk pregnancies, as well as training rural EMS in maternal health emergencies. Behavioral health was also an issue that came up a lot in states' applications and in their project priorities. So looking at that intersection. Another important aspect is how tribes are represented and not represented in the awards, how much money they received, or rather which specific initiatives were stipulated for and by them. Because we know that American Indian, Alaska Native, and Native Hawaiian people have some really stark health disparities, and a good number live in rural areas, and tribes are sovereign nations.
You have some interesting coverage about states requiring insurers to cover non-opioid pain medications. What had the insurers been resistant to do so? Why have they been resistant?
Yeah, to be more specific, this resistance, it's really a lack of parity when it comes to coverage of non-opioid pain meds versus opioids. So opioids in the US are really quite cheap. Opioids are abundant. Opioids are also commonly available in generic forms. In contrast, a new to the market, non-addictive, non-opioid pain prescription med can be more expensive simply because it's newer to the market and not available in the generic form. The FDA, for example, last year approved a new drug called Jornavax, the brand name, which is the first non-opioid pain relief medication in a new class of analgesic drugs, and that's about $15 per tablet. And so insurers or plans may instill higher copays for non-opioid prescription pain meds compared to copays for opioids. Insurers may also require step therapy, which is that fail first, trying something else first, something cheaper, or prior authorizations, all of which caused delays in a patient getting the med. One clinical pharmacist told me she daily has to appeal when filling prescriptions for non-opioid therapies. Another clinical pharmacist told me insurance plans often, avoid covering prescription strength, NSAIDs, nonsteroidal anti-inflammatories like ibuprofen, because they'd rather people pay out of pocket for the lower strength over-the-counter version.
Maybe I can just, since we're talking about drugs, get a question in about 340B. What are you hearing about legislation on that front? Maybe to everyone.
Well, I haven't heard a lot about legislation on that front, but there are still a lot of people talking about it, right, more sort of in the advocate sort of class than on Capitol Hill. But I know Bill Cassidy, the endangered Bill Cassidy, certainly is asking about, what we can do to change the program. There's a strong sense that some hospitals are abusing it, and that perhaps it contributes to hospitals growing too large, buying up little clinics so that they can get into the 340B program, things like that. So there is a certain emphasis on Capitol Hill amongst not too many of them, because a lot of them don't want to hurt hospitals any more than they feel like they may already have. But it's sort of a low boil beneath the surface, I would say.
Interesting. And thank you for keeping an eye on it. Michael, there are a relatively large number of physicians who are running for the House as Democrats. We're really curious, how confident do you think the party is that being a physician is maybe a advantage or a winning point? Do you think that they will do well at the ballot box as a group? Any comments on that?
I don't know how the party as a whole feels, but I do know that there are a couple of PACs out there who have formed precisely to promote not just doctors, but scientists, mathematicians. Doctors and nurses seem to be the big part. And I'm watching this California primary. I believe it's California 6, where Dr. Amy Barra used to be or still is the representative, but under redistricting, he's going to a different district. So you got a primary there where you have a member of Congress who's a Republican, moderate Kevin Kiley, who, he talks about supporting healthcare and things like that, but he voted for the big, beautiful bill, and he wanted to keep the ACA tax credits around, but he still voted against the 3-year extension, right? One of the Democrats running, and they have these jungle primaries out there, so it gets a little bit complicated, is a doctor. And I'll be really curious to see how well he does versus the sort of moderate Republican and the other regular Democrats running. And I think that'll give us a good window into how the voters feel about it, if not necessarily what, the party bosses. I think the party bosses just want, some good looking candidate who can get out there, and they'll take them an ex-Marine or a doctor or whatever they can get their name from.
Or a farmer. Well, we've covered a lot of items today, but maybe a question for all three of you. What are emerging health public policy issues on the horizon that we've not discussed so far that you have a keen interest in?
Well, I've been trying to look around for what hasn't happened this year. At some point, we'll do that story. And the thing that I've heard a lot about is all right, what are we going to do about doctors' pay? Right? They had a little stopgap, in there, but it runs out at the end of the year. And you've got an election season where no one really wants to spend money. So a lot of lobbyists think there'll be some sort of attempt to address that in a lame duck session after the elections. And it was interesting when they did the current round of government funding, most of the healthcare priorities, they put a calendar year date on, so they end in December rather than September 30th, which is the usual fiscal year on Capitol Hill. So there's a lot of stuff. There's more stuff that has to be extended. And so there is talk about all right, what might we want to attach in a lame duck, and doctors' pay was one of the things I've heard people talking about. Will that happen? I don't know. Congress is very, very hard to predict lately.
I have no idea whether the issue is more or less, but that's all right. We'll leave that, and I'll find out in the discussion. Neda or Sandhya?
Yeah, I think, Sandhya mentioned earlier about HIV coverage and state assistance programs. Funding has been really flat for quite a long time. And states are looking to do, instill cost containment measures, interested to see how those really play out and how people are affected. But also health equity efforts that have been sort of targeted by the federal administration or sort of canceled DEI initiatives across, state, nonprofit, and university health systems, and how that will really, affect populations that, experience health disparities, and seeing how these groups try to find other funding streams to support those initiatives.
And there's certainly an enormous amount of cuts coming out of NIH that focus those areas. Right. So we'll keep an eye out.
And drug assistance for HIV patients.
Yeah. Sandhya?
Yeah, I think I will be interested to just kind of see how the messaging changes in terms of priorities kind of more broadly with this being a midterm election year. We touched a little bit on this earlier before, but if there are certain things we're starting to downplay and kind of raise up just because of how the political appetite them for is different. So, just are we changing the messaging on vaccines because of, how that is, or is it shifting a lot more towards some of the other MAHA ideas? And just kind of how that plays out across different, regulations and things. I think that'll be kind of interesting to watch.
And do you think the air will be sucked out around healthcare, around the war out there, that healthcare will take a backseat to all these issues?
I don't know that healthcare is ever out of the hot seat, even if we have a war going on. There's always something.
Well, there is a little silver lining to when there are other big issues, and that is the staffers and the stakeholders in healthcare can have conversations, behind the scenes more easily, and then when the spotlight is right on them, like it was with the ACA or with the big beautiful bill. So when the government was shut down, a lot of stuff actually moved forward, and a lot of sponsors got added to bills. So maybe they can get that lame duck package together while everyone's upset about the war.
Thank you, Neda, Michael, and Sandhya for joining us. And thank you to our audience for being here. Just a reminder, be sure to subscribe to our videos on YouTube, find us on Facebook and X, and also share your thoughts and comments about this program. Take care and be well. This This copyrighted program is produced by Conversations on Healthcare and cannot be reproduced or retransmitted in whole or in part without the express written consent from Community Health Center, Inc. The views expressed by guests are their own, and they do not necessarily reflect the opinion of Conversations on Healthcare or its affiliated entities.